Good afternoon, everybody. This is Danny Gilbert with Healthcare Business Specialists. I'm filling in for Mark Lynn today. We would like to welcome you to the RHC Benchmarks and Performance Measurement webinar with Gregory Wolf from LilyPad. Jonathan Pettenberg from Wintergreen will also be joining us as a panelist for today's webinar. Most of you already know Mark Lynn, who's on a well-deserved vacation this week. Here's his contact information if you don't already have it and if you need to get a hold of him. Here's my contact information as well. Today, I'll be in the background sorting through the questions that come in and available to assist with any technical issues that may arise during the session. A little bit about what we do at Healthcare Business Specialists. We offer a variety of services designed to assist physician practices and RHCs in providing better primary medical services to underserved rural communities by enhancing Medicare and Medicaid reimbursement and keeping RHCs compliant with rural health clinic program requirements. Here's a listing of some of the services that we provide. Once the webinar has ended, the slides from today's webinar and other resources can be found on our website at ruralhealthclinic.com, along with a video of today's webinar that we'll post once it's over, so that you can go back and watch it at a later date or share it with other individuals that may not be able to be here today or that could benefit from it. If you're not already a member of our RHC Information Exchange group on Facebook, please consider joining. We have over 3,700 members on the page, and this is where you can ask questions, post events, or any other items of interest to RHCs. If you have any questions during the webinar, you can type those into the question section of the GoToWebinar sidebar, and we will address those at the end of the presentation if time allows. Without further ado, I'm going to turn it over to Greg and let him tell you a little more about LilyPad and what services they can offer to your RHC.
Thanks, Danny. Let me pull up in my slides. Will I get a box inviting me to do that? Ah, this is promising.
Just send it over to you.
So let's see here. I see me, and how do I do that? I don't see a box letting me show my screen, Danny. So see webcam, screenshot,
Maybe.
look at other people's webcams.
Oh, this says you denied my request, so let me shoot it over again.
Oh, you know, it was because it was saying, do I want to give it the ability to record my screen, and I didn't set that up as a permission in GoToWebinar. Is that going to be a problem?
You didn't give your screen permission? Is that what you said?
Yeah, under GoToWebinar, there's a setting in the permissions, and I don't have a problem with it being recorded, but the problem is I don't have it set up to do that. So it's going to log me out once I say it can record.
Do you see the sharing box in the side panel?
Let me take a look. Dashboard, attendees, audio, webcam, questions, polls, chat, sharing. Yes, show.
Okay. There should be a show, and you should be able to drop down to screen.
And then it says it would like to capture the screen, deny or open system preferences. I'm worried that if I open system preferences, which I will do, it's going to kick me out. Let's give it a shot. Sorry, everybody. It's going to kick me out. Jonathan's going to sing a show tune from Oklahoma in the next 45 seconds. I'm going to click this button and call back in 45 seconds. Sorry, everybody.
So with Craig logging back in, what I'll do is I will kick things off a little bit and have a conversation really around what we're looking to accomplish today. Now, as we're looking at really the importance of benchmarks and performance measurement, what we really want to look at is starting with the conceptual framework of really needing to merge quality and finance going forward. And when we look at from an approach of how we want to look at measurement and approach going forward, oftentimes quality and finance have been very much segmented and kept as separate from an analysis perspective. And what we're coming to realize in the current environment, particularly in the environment where there's been that change in the reimbursement, and our expenses are increasing at a greater rate than the upper payment limit going forward, particularly because it's tied to the Medicare Economic Index, what we need to start doing is focusing on those ways that we can bridge that gap between quality and finance. Now, as we talk through the performance measurement going forward today, as Greg's pulling up his presentation, we've really built it around the framework of leveraging that data as that core foundational approach and looking at how we can leverage that data as a means to start to drive performance improvement. And what I would say is this is one of the biggest opportunities that we can look at as organizations is leveraging the data that we have really as that invaluable resource. And I would say it's something that is often overlooked at many rural health clinics is leveraging the data, whether it's patient data, whether it's financial data, whether it's the collective of both, of leveraging that to drive performance improvement going forward. So I do have Greg back on, and I see he's got his slide deck pulled open. But as we talk through today, again, it's very much going to be framed from that conceptual framework going forward of how we can start to leverage that data for performance improvement. And again, really use it as a means to drive strategic planning and outcomes going forward. So Greg, hopefully you're back up now, and I'm going to turn it back over to you.
All right, good. Thank you, Jonathan. Hey, Danny, can you see me? Can you hear me?
We can.
See the slides.
Yes, sir. Perfect.
Okay, so do I get some points for being unflappable and being able to set that setting and calling back in so quickly? I mean, I don't know.
Well, because technically I'm the one that had to carry it while you disappeared.
I have no idea how I was able to do that so quickly. That's incredible. I didn't think I was ever going to come back. Anyway, I apologize to the group for not having that set up, but it's a heck of a comeback. So my understanding of this group is its origins came out of a Facebook group, and we're all rural health clinic folks. And so what I understand from Mark and Danny is that this is a group that convenes from time to time, typically during lunch, and we talk about important things for rural health clinics. And Jonathan and I are here to share with you some of the things that we see across the country and do our best to impart to you some new information and maybe some ideas. And thank you for an opportunity to do that. So we wanted to start off with a little bit of data, and so let's jump right in. Jonathan referenced the RHC Modernization Act back from December of 2020. And that changed reimbursement for every rural health clinic, whether it's independent or provider-based. And as we run the numbers, and I'll let Jonathan talk about a slide in just a couple of minutes that looks at the final projected impact. What happened was gone are the days of full cost-based reimbursement for the provider-based rural health clinics. And that, for many organizations, is going to present an entire new set of unexpected challenges. For the independent rural health clinics, your rate is going to go up with a nice trajectory culminating at $190 per visit in 2028. And it's a little bit of a good news, bad news piece of legislation that went into effect in April. But what we like to talk about is, what does this mean for all rural health clinics, and where are the new opportunities and where are the new challenges? It really hit the provider-based rural health clinics. We're already now today over 5,000 RHCs in the country, and we're inching toward 3/4 of them being owned and operated by hospitals, most of them critical access hospitals. And depending on where you're from, that's going to hit you a little bit harder. In Texas and Kansas, it's 69 and 70 of the rural health of the critical access hospitals, they're going to be impacted. So it's a pretty big deal, and I'm presuming that everybody on this group is aware of it. And I encourage you to have really modeled out and have an expectation for what the first year's reimbursement impact is going to be on your organization. Now, part of the reason the legislation came to be, at least from our perspective, is the mythology that rural health clinics are absurdly expensive, that the costs are just way out of line, unsupportable, and things just have to change. And as you look at the data, it doesn't really tell us that story. But part of the challenge we have, as Jonathan mentioned, the importance of data, when we don't have really good defensible information about clinics, bad things can happen to us. Information vacuums are not good from a policy standpoint for us. So one of the drums that we'll continue to beat during this webinar is we really got to pull ourselves up by our bootstraps and get serious about collecting data, especially quality data. But when you look at the distribution and the bands of cost per visit for rural health clinics, it really does tell us a different story. Now, sure, there are some clinics that have really, really high rates. Those typically can be explained away from partial year data or organizations that have a lot of specialty services and very low volumes. But for the most part, they cluster in and around, $150 to $250 per visit. And when you think about especially the provider-based rural health clinics, that makes very good sense because of the overhead allocation that's coming from largely the hospital-based inpatient services. So I share this slide because there is this, I would argue, misunderstanding around just how expensive rural health clinics are, but that it's a driver and really an accelerant for people to use those, that confusion, that misunderstanding, and create and apply policies that are potentially really pretty destructive to our rural health clinics. And Jonathan, I'll let you jump in and share this slide, but this is the result of us running the numbers on a go-forward basis up to 2028. Jonathan, you want to go over this slide, please?
Yeah, what we ended up looking at when we looked at the analysis relative to the average cost increase for all of the rural health clinics across the country, what we really wanted to look at was what is the net impact on a state-by-state basis. Again, as Greg had mentioned, with the upper payment limit increasing for our independents and our greater than 50 beds, but then us also capping that payment on our fewer than 50 beds, those provider-based rural health clinics that used to receive the uncapped cost-based reimbursement, how does this play out in the future? Now, again, not getting into the politics of whether or not it should have passed or should not have passed, what Greg and I very much want to do is just look at it from a data approach again and say, what do the numbers show relative to those cost increases? Now, what we've seen when we looked at all of those numbers is the average cost increase for the rural health clinics from 2015 through 2020 based on cost report information. For our provider-based rural health clinics, they saw about a 6.5% annual increase in their cost. And the independent clinics saw about a 5.5% increase in their cost. Now, when we look at the map of the United States on the left for 2021, and the range is between a $2 million positive to a $2 million negative, the green states show those states that are going to be better off because of the passing of the law, and the red states are the ones that are going to be worse off. And again, when we look at the numbers, because the Medicare Economic Index is increasing, this past year it was 2.1%, at a greater rate than what our cost is going up, eventually our provider-based rural health clinics are going to be in a worse position in the future. But as we get all the way out to 2028, again, because if our cost keeps increasing every year at 5–6%, and the MEI is capped at that 2%, eventually there's going to have that compounding effect where more and more states are going to be negatively impacted. Now, again, all this is looking at is the difference in the reimbursements between the two models. Does not get into the sustainability of the programs, does not get into the cost of care, does not address any of those different factors. Now, what these maps highlight is that the status quo has changed. As Greg had mentioned, gone are the days of cost-based reimbursement, uncapped cost-based reimbursement. And going forward, we have to start to evaluate our clinics and focus on different ways to increase revenue and control costs because of the way that that program is reimbursed and structured. And it very much brings forth the relevance of data and performance improvement and outcomes as we continue to look going forward. And really what it shows is that if we continue in that status quo environment, we're going to continue to be in a position where the financial performance or the reimbursements received for those clinics continues to decline. So again, very much data is key going forward.
Thanks, Jonathan. And then the punchline is, and this goes back to the other theme that we want to hit, in addition to data is really important, the linkage between quality and finance. And so NRHA's formal policy position is they are requesting to Congress, and there are a couple of bills in play right now, that the full uncapped cost-based rate for the provider-based rural health clinics be reinstated in exchange for voluntary public reporting of quality measures by provider-based rural health clinics, or arguably all rural health clinics. And I share this slide because many rural health clinics, are not formally and faithfully tracking quality improvement metrics, and are not prepared for public reporting. And so you will hear from us as we go through the balance of the presentation, both sort of a clarion call around, hey, we need to get sharper around data and information. Finance and quality are inextricably linked, and there is a new environment, a new set of pressures financially, especially on the provider-based rural health clinics. So the pressure is on, and that's okay. We're going to do great, but we have to work with each other to learn from one another and make sure that we're all advancing this agenda together. And meetings like this today are a way of doing that. So real quickly, a little bit about LilyPad, my company, and the work that I do with Jonathan. So we've been at it almost a decade now. And so what we recognized was there was a big gap between resources that are available to critical access hospitals through a FLEX program, that's a HRSA federal grant, the SHIP program, the State Office of Rural Health program, and FQHCs have the 330 grant. But we're now looking at 5,000 rural health clinics, and they don't have a funding source, and we don't have data. And for the most part, clinics did not have tools or technical assistance coming from their Office of Rural Health with dedicated funding to really focus on these things. And so we've continued to build tools and capabilities and data sets specifically for small rural primary care practices with a focus on rural health clinics, because we know how important they are strategically. But here again, not enough information and not enough, I would say, managerial discipline around running practices, in part because you are cost-based reimbursed for Medicare and in most states, Medicaid. And that's a great cushion to have, but that cushion's now gone. So these are the states where we currently work, and I suspect many of you are in states shown here on the map. And if you're not already using Pond, we want to encourage you to do that. But what we're trying to do is we're trying to do things the rural way, and that is grassroots, from the ground up. Let's work together and try to build a database so we can learn from one another and fill that information gap. Pond has two parts to it. We've got publicly available data that allows us to look at benchmarks within a state or regionally or nationally. And we also have the original application we built. It's a lot like MGMA. So if any of you are responsible for provider contracting or compliance, and you're familiar with MGMA, you know that is essentially an annual survey that gets completed. And in exchange for your participation in that, you're able to get benchmarks around compensation and productivity for providers. So Pond does that, but it's just for small rural primary care practices. And unlike MGMA, where you have to pay for the privilege of data collection, reporting, and benchmarking, in all the states where we work, clinics never pay a dime. Everything is paid for by the State Office of Rural Health with a federal grant. So plenty of excuses not to fight the good fight and start the process of collecting and reporting and benchmarking data, but in those states where we work, the program's available at no cost. And then obviously, once we collect the data, we're able to generate all kinds of reports. the report in the upper left-hand corner, that's the report that we're going to really focus on for the balance of our presentation, because that becomes the agenda, if you will, for what we like to consider the 20 most important questions that we think all rural health clinics should be asking and should be able to answer. And we're going to go over those very quickly on this webinar, but as Danny mentioned, all of the slides will be available to you once we're done. So no shortage of data, no shortage of comparative analytics, at least for the clinics in those states where we're working. And then what we do here is a little bit uncommon in the sense that there's just a bunch of things you can do out there if you're a rural provider, whether a hospital or a clinic, where you can provide data and generate reports, and it sort of stops there. We make sure we don't stop there. What we want to do is we want to then work with you and actually help you interpret the report, talk to you about how to use the information, and then we'll spend time with you and actually talk about some of the improvement opportunities that you probably have in your organization. And this is the important part in our states really demanded of us. It's making sure that it's not just data for data's sake, but instead use the data to set up the conversation to figure out what your priorities should be. So that's the background on POND, because as we go through this, there'll be a couple of references to data. And you may be wondering, if you're not somebody who's in one of those states and already using it, you may wonder, where can I go to get my hands on data? I'd like to compare myself in terms of productivity or cost or staffing model or compensation. And so that is what will get referenced for the balance of today's presentation. I always like to start off with this slide because it sort of lays out the schematic on how we think about rural health clinics. I know it's a little heretical, but I've gotten comfortable saying that in a rural community, especially with one of those communities with a critical access hospital, the single most important department is the rural health clinic. It's actually more important than the emergency department. But too often the RHCs get subordinated, especially from a critical access hospital quality improvement program aspect. And so part of what we do is make sure that rural health clinics not only have a seat at the table when the hospital is looking at performance, but that you're actually at the head of the table. And that's because from a strategy standpoint, the clinics are incredibly important. And quite frankly, with in an era of increasing population health and alternative payment models, revenue comes in through primary care, and the hospital is a cost center. And so that change in polarity is something that's already occurring and will only become more pronounced in the future. And then we break down operations into finance and quality. And of course, finance gets broken down into money in and money out, revenue and expense. You'll see on each of these bubbles a number, and those numbers then link to what has been promised to you is the 20 most important questions we think all rural health clinics should ask and be able to answer. And so Jonathan and I are going to do what I like to call a little bit of speed dating, because we've got about 90 seconds per question, but we do want to go through each of these questions with you. And again, you'll have the slides so you can refer back to them. But as I go through each of these questions, I'll ask Jonathan to jump in and offer color commentary. And again, referencing the summary report that you get from POND, it's got these different sections where we collect information, we give you benchmarks, and then we calculate all these measures for you. And we do that one time per year, and we call that the POND summary report. You'll see this referenced as we go through each of the questions. All right, let's do question number 1. Why do visit volumes matter so much? And I hope nobody on the call is questioning whether or not visit volumes are important, because that's probably the single most important key driver in terms of financial performance. So Jonathan, jump in. Why are visits so important? And you get 60 seconds to answer that question.
So the reason visits are so important for a rural health clinic is because it plays a significant role, actually a material role, in determining your upper payment limit and the cost-based reimbursements that you receive for the services provided. Now, oftentimes in rural health clinics, they will often focus on the expense side and really try to cut their way to success. Now, I'm going to tell you that that's really not possible as a rural health clinic. And the reason for that is because you have to have staff available to provide those services. And even if patients do not show up, you still are operating within the hours of operation that you've established for that rural health clinic. Now, because the overwhelming majority of your cost as a rural health clinic is fixed and not variable, as you increase your volume at that rural health clinic, you will continue to dilute down the cost per unit of service. Now, what I'll tell you is as a rural health clinic, it's the same thing as a critical access hospital. The way you make margin or profit as a rural health clinic is to ultimately dilute down that cost per unit of service so that it's less than what you're receiving from your commercial payers or those non-cost-based titrated rates. So again, this is why volume is so important, because it helps to drive down that cost going forward.
Thanks, Jonathan. And that's why on the summary report, the first big box is visit volumes. That's the key driver. And the visit volumes actually is the single most important variable in all kinds of performance ratios that we would encourage clinics to use on management reports. And those are listed here. We're already going too slow, I think. So we'll see how we do. 1 down, 19 to go. Question 2. What's the right mix of physicians and advanced practice providers? And this is the part I like where I get to say it depends. I always like saying it depends. Generally speaking, the marker that we start off with is a ratio of 3 advanced practice providers for every 1 FTE physician. Now, is that the absolute correct answer? No, by no means. There's 24 factors that will cause your clinic to have a different ratio than exactly 3 to 1. But 3 to 1 for us is a pretty good starting point. And Jonathan, you want to talk about how we arrived at that number?
Sure. What we looked at is we looked across the country and we started again diving into that different data. And what we looked at was the services that can generally be provided within a rural health clinic. And oftentimes there's been an over-reliance on physician-level providers in many of these rural health clinics. Now, when the rural health clinic program was pushed out, it did have written in that regulation that you had to have an APP available at least 50% of the time the clinic is open. But what it didn't do is it really didn't look at the levels of care, the continuity of care, and the services that are really requested by those patients within those rural communities. Now, when we looked at different things of looking at also from a supervisory perspective and all of those different areas, the blend of 3 APPs to 1 physician allows you to effectively serve your patient population, meet the supervisory requirements, and also continue to push those services going forward. Again, we have to get away from that over-reliance on physician-level providers. And this is something we particularly seen in that COVID pandemic, because we've seen more of a transition of providers moving between different locations, that we can now look at a means to increase the APPs within those different practices also.
Question number 3, are our providers busy? The answer, if they ask you, is yes, you're very busy, you're very productive. We are so fortunate to have you. Is there anything else I can do to make you happy? But how you answer that question, if they're not in the room, a good place to start is the Medicare minimum productivity standard. And so the first test of whether or not your providers are busy is if they're a physician for every FTE, you would expect 4,200 visits, and PAs and nurse practitioners, it's 2,100. So that's the quick way of answering that. Now, like the previous question and answer, there's all kinds of factors that might cause these numbers to go up or down. We could spend another hour just going over at a high level those different reasons, but a good test is whether or not you're meeting these different productivity standards. I will tell you, In most states, the average is around 60 to 70% of the clinics are meeting those productivity standards. And it typically is one of the first places where Jonathan and I will go to look at improvement opportunities. Because if you're not at least hitting those numbers, there's probably a handful of operational improvements that can be made. Again, for today's call, we can't get into those details. But for those of you who are looking for a quick yes, no, red light, green light answer, that's where we would encourage you to go. And if you can't today go out and generate a report and look at the last fiscal year or last calendar year and get your visit statistics by provider, that would be the first thing you want to do when we're done on this call today. You need to make sure you've got your fingers, you've got those numbers available and right at your fingertips. In the summary report, we calculate those visits, and we also look at work RVUs. Now, a side point on work RVUs, just in the last month, it's been a little disconcerting and mind-boggling how many practices are not tracking RVUs. If you are not tracking relative value units on a provider by provider basis, that would be a good thing to start this week as well, because you'll see one of the questions we'll have in a little bit relates to compensation. And most compensation plans today have some component of that related to productivity, and productivity really should be evaluated on an RVU basis. Jonathan, I let you off the hook for question 3. Now we've got question 4. So what's the difference between gross charges and net revenue? I like to think of it as going on new car shopping and you look at the sticker on the window and you laugh and you say, I'm not paying that amount of money for that car. That's the gross charge. It's the MSRP. It's not really what you're going to pay. What you're really going to pay is depending on your payer. But as a practice or as a hospital, you will account for that cash using net revenue. Gross charges is the listed price, probably not what someone's going to pay unless they're paying cash. Net revenue is how much the clinic will actually earn in terms of income. Jonathan, could you walk us through why this is really, really important to a provider-based rural health clinic?
Yeah, it's not just provider-based rural health clinics. It's really when we look at all of our rural health clinics going forward. Now, when we look at our rural health clinics, again, the reimbursement methodology and how we actually determine cost and structure plays a specific, particularly on the charge side when we're determining what we're going to charge for our patients. Now, in an environment where it's greatly more competitive, particularly with our freestanding clinics and other hospital-based practices, because our charge structure determines the out-of-pocket expenses for our Medicare population, we want to ensure that we do not overcharge for the services that we're providing. And the reason for that is because the 20% of charge portion that is attributed to that patient population, that Medicare population. So what ends up happening is say we have a 99213 and we're charging $200 for that service. The coinsurance passed on to that Medicare beneficiary is the 20% of $200. Now, when you compare that to their coinsurance deductible that they may have in another location, this is where our patient population is growing much more savvy relative to the cost of care. So what we want to do is when we establish our price list, we want to ensure that we are competitive in our current market, but we are not overpricing ourselves. That now puts us at a competitive disadvantage because that patient population is going to receive services elsewhere.
Thanks, Jonathan. And there's an interesting anecdote in a mid-Atlantic state with a large health system that I won't tell you the whole story, but essentially this rural community was paying for all of their care out of pocket. Medicare themselves were not reimbursing anything because of the way they've set up the charge structure. So if you haven't taken a look at your charge master recently, I want to strongly encourage you to do that. It would seem to me that we don't want Medicare beneficiaries paying out of pocket for services that Medicare should be covering. All right, so we've covered that. Let's go to question 5. How come our clinic does not make money? Now, if you've been listening to the previous questions and answers, you'll get into a rhythm. There's a common answer to a lot of these questions. So how come our clinic does not make money? Well, really, it comes down from a financial perspective to money in, revenue, money out, expense. If you've got money left over, that's called profit. And so you ask yourself, okay, well, how do we drive profit? And it's really around these key drivers. And I would say visit volumes here again, that's the most important factor. On our report, we look at profit margin. So what you'll be able to see then is your profit margin for the year. And then you'll be able to compare yourself against a cohort of other rural health clinics, and then also get the national standard, the US cohort standard. But you can see some of these key drivers. If you're looking for some kind of checklist, if you're asking yourself, how come you're not making money? This would be the starter list of factors that we would encourage you to look at. And we've already hit on a couple of them. Here's an important question because, as I mentioned earlier, a lot of clinics are not even tracking quality measures. I mean, they're just not. Whether the EMR is not set up to do it and people don't want to do it manually, I understand. I wouldn't want to collect data manually either. Or they're not part of an ACO and they're not doing MIPS and it's not something that's required and therefore it just goes to the bottom of the pile and it doesn't get done. We want to encourage you, find time and resources, especially if you're provider based and the hospital has a quality improvement director, get some help and start tracking measures. And the measures you should track comes out of a field testing process and research that resulted in 5 key National Quality Forum measures. And I think I have them listed. Nope, I don't have them listed. They're in the report. You'll be able to see these. But there's 5 common NQF measures that we encourage all clinics to track. And really, just pick one. If you don't have a lot of time and resources, just pick one and start tracking it, but get into the habit of collecting information, putting it on a report, looking at it together as a multidisciplinary team. This is the kind of thing that you will have to do in the future, and now is the time to start practicing that. If anybody wants the list of these measures with links for how to calculate them and resources, I've got a nice little 1-pager. I'm happy to include it. Actually, Danny, what I'll do is when we're done today, I'll send you that PDF and you can include that in the follow-up email that'll have the link to the recording.
Perfect.
Are our providers appropriately compensated? The answer to their face is no, we just wish we could pay you more. We're so lucky to have you here. When they're not in the room, you may look at 2 key interrelated categories. One is productivity. That's how busy they are. And again, if you were paying attention 3.5 minutes ago, the unit of analysis for that should not be visits. The unit of analysis should really be RVUs. And again, if you're not tracking RVUs, I would encourage you to start doing that. And then that ties back to compensation. And so when we think about compensation, and we have a slide on this in just a couple of minutes, it's really increasingly a mixture of base salary and then variable compensation. And that variable compensation is a portfolio of different kinds of inputs or quality and patient satisfaction components that go into the extra amount of money that providers get paid on top of their base we Some clinics don't even have base salary. It's only based on productivity. And that's a model in the for-profit world that has served them very well. We don't see it very often in rural, but the 2 ends of the spectrum can be pretty extreme. Do we have the right number of support staff? So Jonathan, if you want to talk just real quickly about the concept of team-based care, so folks are at least aware of that if they're not already. We don't have enough time to go into great detail, but that we're seeing a growing number of practices that are focusing on team-based care.
Yeah, one of the key concepts of team-based care, and this is something that could definitely help many rural communities, particularly our rural health clinics across the country, is starting to get all of our individuals within that clinic to really operate at the top of their license. And one of the core functional approaches to that is, if a MA can do something, then it doesn't make sense to have a nurse do it. If a nurse can do something, it doesn't make sense to have your provider do it. And what it is it's really getting our providers and individuals to start looking at the things that are required for their specific licensure and starting to focus on that team-based approach going forward to improve patient outcomes and the care delivery. And again, it really focuses on getting the individual at those lower levels and to start assigning and delegating work to those individuals. You know, if a provider wants to, just because they want to room a patient or do vitals or do different things like that, because that's the way they've always done it, that is not something that's going to work for us, particularly in this new environment where we are being capped at at the MEI going forward. So that's very much the team-based approach there.
Thanks, Jonathan. How can we control our cost per visit? I'm going to speed this up a little bit because we're already at 40 minutes in and I want to leave time for any questions, but we'll speed this up a little bit, give you some shorthand answers. Key drivers for cost per visit. Again, the visits tend to fix a lot of sins. The extent to which you can increase your visit volume, a lot of ratios then come back in line. With greater visits comes greater productivity. You're using your providers more effectively, more efficiently. It'll also bring down your staffing metrics. And there's this really wonderful mesh of factors that all play together, and most of them use as a fulcrum the visit volume. And so when you're able to increase those visit volumes, all the other interactive pieces that you look at from a ratio standpoint tend to come back in line and improve. So ironically, when you're thinking about expense management, the most important thing you can do is to increase those volumes. Why is it important to track new patients? New patients represent the fact that your practice is growing, it's thriving, it's a place where patients want to come and receive care. You're going to naturally have attrition over time, especially in rural communities with a lot of patients who are elderly. And the extent to which you're tracking new patients, that's the leading indicator of the overall vitality of your practice. Most electronic medical records let you encode a rule set that determines which patients are new and which patients are not. Would encourage you to light up that component of your electronic health record and make that a metric that you track. What's most important, managing visits, revenue, or expenses? For those of you who have been listening while you're clearing your email inbox, you'll know that the key driver is visits, and visits tend to impact revenue and expense almost directly. And so you can see the ratios that are going to be impacted as we increase our volumes. Now, if somebody said tomorrow we're moving into a world of universal coverage, single payer, now it's a communist Russia, and that's the way our health system works, then this completely goes away. Completely different delivery model. The promise of population health was that the imperative around increasing productivity translated by visit volumes, that was slowly going to go away. And we started to see some of that with the advent of ACOs. But we've not really advanced most reimbursement systems in our country enough to cause us to reach a conclusion that visit volumes are anything other than the most important factor when you're thinking about financial performance of a clinic. So until we have a completely different apparatus in our country, how we deliver care, visit volumes are going to be really, really important. What's the right mix of clinical and non-clinical staff? And this goes back to Jonathan's comments around team-based care. So any activity that does not require in your practice a clinical background, then you should be looking to have people who don't have a clinical background to do that work. because you want your MAs doing what MAs can do up to the top of their license. Your nurses, the same thing, up to the top of their license, PAs, NPs, and especially your physicians. So there's no right answer to this question other than the extent to which you are making sure that everybody every day is doing only those things that they can do. That is how you're going to wring as much efficiency as possible out of your system. What level of performance should we expect for quality measures? This is somewhat of a philosophical question, because on the one hand, there are QI experts or nurses or physician executives who will say, for a quality measure, your target should always be perfect, or 100%, or 0%, depending on the metric you're looking at. Others would take a slightly different approach and say, I want to know how we're performing now, and we're going to set a stretch goal. And once we hit that stretch goal, then we're going to move the goalposts and set another stretch goal. We're going to build momentum and move toward that perfect score. That's a culture, an organizational culture and philosophical question. But what we want clinics to do is to not just collect data and stop. We want you to collect data and report the data and use the data. And we don't want you to stop there. We want you to use the data to make decisions. And we want you to share the information, but we also want you to set targets so that when you look at a specific score on a measure, you're comparing your actual score to the target that you have set, the aspirational goal that you have achieved through a consensus building process. That's when you'll start to see improvement, when people are all working together, looking at data, trying to achieve the same level of performance. Target setting is key. Too often, it's a missing ingredient. How do we increase profit margin per patient visit? Now, this we've covered. I don't want to go over this too much, but this is where we start looking at commercial contracts and alternative payment models so that you're getting paid for all that work you're doing, specifically around value-based purchasing arrangements. Depending on the state, you'll see Medicaid programs or Medicaid managed care organizations or your commercial payers. Oddly enough, they're very eager to work with rural health clinics and critical access hospitals to develop creative approaches to increasing reimbursement in exchange for you doing really well around chronic disease management or patient management, because they have, as the payers, they have the downstream cost reduction benefits, and increasingly payers are willing to invest on the upfront process with their provider partners to put these kinds of systems in place. So those are options available to you, and we could spend another hour just talking about different alternative payment models available to RHCs. Okay, we're almost there. Should performance standards be different for PAs and NPs? We talked previously about the productivity standards for physicians and then advanced practice providers. In some ways, the answer to this question is really contingent upon the way you've configured your practice. Are you doing team-based care? What are you expecting nurse practitioners to do? What kind of and what level of physician supervision is being offered? And what services are you offering in your practice? But generally speaking, you should be looking for NPs and PAs to be operating pretty much at the same level of throughput. And again, the signal question for that group of providers is, are they at least seeing 2,100 patients per year per FTE? How does patient panel size factor into overall performance? We'll talk in just a second about compensation for providers, and panel size is a new factor that we see more and more in the development of compensation packages for nurse practitioners, PAs, but especially doctors. But when we talk about the advent of population health, panel size is important because to track this, you need to create panels. And far too often, we'll work with a rural health clinic, and not only do they not create and manage according to patient panels. They don't know what a patient panel is. So a patient panel is a roster of patients that are assigned to an individual provider, or ideally a provider team. And that helps boost accountability at the individual team or provider level, and also allows you to track other metrics on a patient by patient basis, and also allows you to assign patients with specific clinical conditions to providers that have unique backgrounds or training. So we would encourage you to start the process of creating patient panels and tracking those numbers for your providers. It's an interesting little aspect of provider compensation, which is our next question, which is what's the best model? There is no best model. The best model is the one that's going to provide the best care to your community and to your patients, and one that's consistent with what the providers are expecting and needing, again, within reason. We often see base salary as a big chunk of overall compensation, but increasingly we're seeing variable compensation. And within that tranche of compensation for providers, the big piece is RVUs, and that's the best way of translating the activity into billable units. Increasingly, we're seeing clinical quality, patient satisfaction, and then again, panel size. So there is an art and a science in creating compensation packages, especially for doctors. But there are some models out there. We would encourage you to be thinking about not just base salary, but looking at other factors to include. How does visit volume relate to work RVUs? So generally speaking, we see a standard normal distribution of RVUs. If we put enough providers and enough data into a database, it'll come out, generally speaking, as a standard normal distribution. But you'll see that the curve that you will achieve for an RVU is not going to be a perfect overlay of visit volumes, because some visits require greater resources, and some providers see patients in a way either where they document differently, or they're providing services to patients with greater clinical complexity. But here again, you won't know that if you're not tracking it and reporting it and benchmarking it, and then ideally to really influence behavior, linking compensation to productivity based on RVUs. And again, in the POND summary report, you'll be able to get your national benchmarks. Why are our productivity scores low? 4 key reasons. Jonathan, if you want to cover those real quick, and we've already burned past our 45 minutes, but 2 more questions and then we're going to finish this up.
Yeah, really it comes down, and you can see them on the screen, but really it comes down to the willingness of our providers and also the ability to get patients through our facilities. So there's many operational things that can impact productivity scores. Throughput, appointment times, our scheduling, do they have the standard appointment times of 15:30? Are they doing 20:40, 30:60? But a lot of times it comes down to, again, how many patients we can get through our clinics within a given time frame that will ultimately determine those productivity scores. And again, it's really coming from all of the different variables relative to our patient population and our providers that will ultimately dictate those productivity scores. Now, one thing I want to emphasize is, again, we don't want to leave money on the table either. We also want to make sure that the services that we're providing, that we're adequately billing for those services and getting everything from a billing perspective also.
And I would put a pitch into practice managers that the data integrity piece is not insignificant. We repeatedly look at Schedule M's for the provider-based clinics, as well as the independent rural health clinics. And when we look at the FTE values that are put in the cost report for the providers, it is not uncommon for those numbers to not comport to reality. And so the extent to which you are tracking the actual time providers are providing care in the clinic and using those numbers in your ratios is really important. A lot of the statistics that are being tracked are sloppy, and people are making decisions based on bad data. So that's another important jumping off point for clinics that want to start focusing on decision-making using data. All right, last question, do we need to hire more providers? If you can find them And I won't even talk about the nurse shortage or what you have to pay travelers. But you need to hire more providers. Well, obviously, one of the first questions you ask is, are your current providers, are they busy? And again, there was a question on that earlier on this presentation on how to determine if your providers are busy. And again, RVUs is the unit of analysis. But if you're not able to recruit more providers, or you're finding that the providers you have are not optimally productive, then there are different options and alternatives to try to address those failings. And so they're listed here. So that's how we would answer that question. But again, sort of the first way of answering that question is, can you recruit providers to your community? So that covers it for our presentation. We went over like 10 minutes. I apologize for that. And Danny, I don't know if there were any questions that have come in across the transom in the chat box, or if you want to open it up, the microphones for people to ask questions. We're happy to hang out for a few minutes and answer any questions we might get.
Yeah, and you can utilize the question section of the GoToWebinar sidebar or raise your hand and I can unmute your line. One did come in though. John asked, do you see physicians resist a large percentage of their compensation based on variables?
Jonathan, you want to answer that?
Sure. I wish there was one size fits all approach. There definitely is not. And it depends upon the relationship and the trust you've built with those providers. Now, I will say that it is important to get them to gain an understanding as to the reason and the logic behind the variables. But the industry standard these days from a best practice approach is really to establish compensation based on some type of base salary, plus work RVUs, plus patient satisfaction scores. And then the last one, which is also important, particularly in an ACO environment, is to build in patient panel sizes also as a percentage for that. And that's definitely what we're seeing in today's environment. But anytime you try to transition providers and work on their compensation, it is a conversation, and sometimes it is more difficult than one would think.
I think there's a generational factor as well. And so freshly minted, especially physicians, depending on sort of their attitude and how they want to practice, some of them are willing to quickly go at risk and be productivity based, the eat what you kill model. Others are graduating and they're starting their practice and they're really, wanting to make sure they're home by 4:30 to take their kids to soccer practice. So it really does depend generationally, but also on the personality and the precedence and the legacy of the individual. And I think that's, it's a very, obviously very sensitive topic, and one that needs to be handled very carefully. But as Jonathan mentioned, we see less and less providers being paid just on base salary. So that's what I would add.
Adding to the RVUs, do you have a formula in order to calculate RVUs?
Well, there's two ways I would answer that. Number one is there's a standard, there's a table, but there's an industry standard that links the CPT code with an RVU value. And most electronic medical records or billing systems have that encoded, and those get updated on an annual basis. I will tell you though, I think the question is really slightly different, which is, and this has happened with clinic after clinic, especially recently, geez, we're not tracking RVUs, but we want to look at RVUs retrospectively. How can I do that? And so what we have done is we've run our numbers internally, and we actually do have a factor. I don't have them memorized, so don't quote me on this, but I will also make sure Danny gets this. But if you are a physician, for every single visit, one visit equals 1.67 RVUs. This is on average. You had to come up with a plug number. And then for advanced practice providers, for every one visit, it's 1.23 RVUs. If you do not want to go back and do chart review and nag your revenue cycle team, which you should not do, and I'm not telling you to do, you can use those plug numbers retroactively, but do start tracking them now. And I'll get that blurb or that arithmetic. I'll make sure that Danny gets that and she'll send that out. Danny, are you keeping a list of promises I'm making? Because I'm going to forget
Yes,
something.
I actually am.
Okay, good. Thank you.
Jill asked, looking at the map of the states you work in, it appears there are many states leading the number of RHCs in the U.S. where you are not working with POND. What is the plan for expansions to other states where you don't currently work with the Office of Rural Health?
So we would like to work in every state. We've reached out to every state. The map that you saw those are the states where the Office of Rural Health has engaged us to implement POND. If you are in a state that is not one of the states where we're currently working, I am not too proud to say I would welcome a chance to talk to you and see if we can make a case to your Office of Rural Health to subscribe to POND on behalf of the clinics in your state. It's really cheap and there's grants that are out there to pay for it. So if you're from a state and your state wasn't lit up and you want to just drop me an email or through Danny, let me know. I'm happy to see if we can make the case to your Office of Rural Health to be part of the community.
Okay, we have one more that came in about the RVUs. Since RHCs are paid the same for all Medicaid visits and most Medicare, do you still look so much at the RVUs?
Jonathan, you want to take that one?
Yeah, you will look at the RVUs from a performance approach. Now, even though it's not directly impacting your reimbursements from Medicare and Medicaid, you still want to be able to track the productivity for your providers. And again, if you have a provider that's doing all 99215s, you can't expect them to do the same number of visits as a provider doing a 99212. So it's very important to track the needs of your patients, and also it's important to track all of those different factors relative to the overall performance of your different providers. Now, as many of us also saw in the past year when they ended up increasing all the RVUs and then tweaked the conversion factor, we do have to take into account and continue to look at the monitoring and the changes to those RVUs. But it does, even if we're not reimbursed to that degree, provide a conceptual framework of the performance of our individual providers.
Hey, Jonathan, I'm not an expert in this, but I'd like to think I'm smart enough to pay attention when people have been talking about this. Isn't there another derivative value in RVUs from a fraud standpoint, such that you would expect in an audit, you would expect that a provider would generally have that standard normal distribution, meaning that there's issues of balance in the RVUs and the E&M codes. And so if you're undercoding or overcoding, they're both not good. And wouldn't the RVUs be another way of tracking that?
Not an accumulative approach. I mean, if you were to add up the value of every service you provide, you would have providers which would have a higher number of RVUs. The CPT codes do provide that good bell curve. You know, you do want to have an equal distribution. There's no practice that should have all 99215s, because then you're most likely overcoding something, or you're justifying something that may not be there. It does, again, it's another data point. There is no single source of data out there that provides you the answer to every single question. So when we look at whether it's looking at CPT distribution or work RVUs or all of those different factors, it's taking all of that different information and using that to drive that decision-making process that we started with this at the beginning.
So RVUs per se that's not even the unit of analysis you would look at in terms of the balance for undercoding or overcoding. You would look at the E&M codes.
Correct. You would trace it back to the CPT codes itself.
Gotcha. Okay.
Because each of those different CPT codes has a corresponding requirement. You know, you got to go to medical necessity. You got to look at all those different factors. You have to meet the core requirements to qualify for each of those different levels. But just by looking at a cumulative value of work RVUs, you wouldn't be able to deduce back to that because you don't know all of the unique codes that make up the cumulative RVU value.
Yeah. See, I learn something new every day too.
Okay, I think that's all the questions that we have. I want to thank you both so much for the presentation information. It was great to have you. If anybody else has any other questions, feel free to email. I believe Greg's got his email address on the screen. If you want to reach out to me, I can get you in touch with him or Jonathan. And I hope you both have a wonderful day and everybody has a great weekend.
Thanks to Mark
Thank you
and
very
Dan.
much. You too.
Very much appreciated.
Thank you.